Hi everyone, my name is Melanie Grant and this is C&M Glass. Today we're going to have a short video on anesthesia coding with CPT for our class 2030, which is our last part of section 1 of this module's class. Anesthesia is a little tricky, so this is a part 1 video. I want to take some time to go over some of the questions you guys might have during coding clinic, and then we'll be readdressing some of the examples that we come up with for anesthesia coding when we get to our coding clinic and our Coding with Miss Melanie segment later on this week. All right, so to get started, anesthesia, there's a few things you want to have in mind that are very unique to this section. The first one is that anesthesia is based off of time. Based off of how long the patient is in the procedure room from the start to stop of anesthesia is how long the anesthesia time units are calculated. Okay, so this is not the surgical time. This is anesthesia time. And you'll find this in your chapter readings. There's an example of an anesthesia note on page 702, which will commonly tell you the time that the patient is in, so that you have pre-sedation and the final time, okay? All the way from 1300 to 1435. You would calculate the entire time the anesthesia was being administered, not the surgery time. So this example here is an example of a very specific anesthetic note. Now keep in mind, when you're coding anesthesia, you're coding for the anesthesiologist, not the surgeon. So your codes are going to be in range 00100 through 01999. This is only for the anesthesia because you're only coding for the anesthesiologist. However, oftentimes you'll have the surgeon's code, or it might be easier to find that code instead of the anesthesia. For that reason, we have what's called an anesthetic crosswalk, and something I'm going to show you guys both in some example activities this week as well as with 3M, where you can compare from the surgery code directly to the anesthesia code. This is a really cool thing, and the crosswalk will often tell you the base units as well. Now, what's a base unit? Well, a base unit with anesthesia is Medicare's way of saying what exactly is entailed in the anesthesia procedure to determine cost. The cost is based off of the total amount of units, which are both base units, B, time, T, and any additional qualifying circumstances which fall under your M. Okay? You'll find this calculation in your chapter readings when you get into page 701 for time reporting, and you have to interpret it any modifying factors, which are your modifiers and qualifying factors, as well as your base and time units. We're going to do a couple activities this week, so don't feel lost on that. It is a little bit confusing. The first thing to know with anesthesia coding is that the code itself is fairly simple. It's all about the type of anesthesia and where it's administered to for the surgery. So if you're having surgery done to the abdomen, for example, you're going to be looking for anesthesia for surgeries to the abdomen. And that's going to give you a code, which you'll then look up a base unit, typically between the numbers of 1 and 5. That base unit will be your first number. So let's say you had the number 5 as your base unit. This is on a separate form. You'll see in Excel that I'll be presenting for you guys this week. So it's very simple. You look up the code, find the unit, add your number. Now let's say you have a patient in for 60 minutes. So you would have 5 plus the time, 60 minutes divided by 15 minutes. Because your time is 1 unit is equal to 15 minutes of time. So that's going to be a total of 4 units for that time. Then you're going to determine if there was any additional qualifying circumstances or modifiers. So let's look at those qualifying circumstances and modifiers for a moment. These are your qualifying circumstances for 99100, 116, and 135. You'll find these referenced in your book on page 702, which are pretty basic. There's no question about whether or not they apply. 99100 applies to a patient of extreme age, and they give the example of younger than a year old or older than 70. So if our patient is 75, having an abdominal procedure performed, we're going to add 99100, and that's going to be worth 1 unit additional for our qualifying factors. Okay, others, anesthesia complicated by total body hypothermia, and anesthesia complicated by controlled hypotension. And then I'm missing on here 99140, anesthesia complicated by emergency circumstances. So if they came into the ER and they need an appendectomy because they have a ruptured appendix, that's an emergency circumstance. Okay? Let's say that our patient is that example. We would also add 99140, which is worth an additional 1 unit. And so you would have both the anesthesia code plus the 9000 code, and you would add the unit to the anesthesia. Think we're done yet? Well, there's one more thing that we need to do, and that's apply our modifiers. Anesthesia codes always have 2 modifiers, no matter what. Your first modifier is going to be either A, G, or Q, which you'll find in your reading on page 705, indicating the person who is administering the anesthesia. And so you have the anesthesiologist themselves, the physician is supervising it, and with concurrent care, which means that they're supervising more than one anesthesia patient at a time. You have monitored anesthesia care for deep patients, and then you have at the medical direction, with qualified individuals. This is like your CRNA has their own QZ versus other individuals. So really just kind of read through those and determine based off of what's indicated. Most of the time it's going to be an anesthesiologist or a CRNA, and with or without concurrent care, and just determining which of those modifiers apply. You'll notice these modifiers all come from your HCPCS code book. Your last one is, or your second modifier, is your P modifier. Every anesthesia patient will have a P modifier. And you have anywhere from P1 to P6, ranging from a normal and happy, healthy patient, which is P1, to a patient with who is dead, according to their brain activity, and they're harvesting for organs. The anesthesia is done for purposes of just in case something is awake. And so we want to make sure they don't wake up, which is your P6. So everywhere in between, the questions I see the most common is the difference between P2 and P3, which is your patients that are normal with mild systemic diseases versus patients with severe systemic diseases. The question here is a systemic disease. What is that definition? It's anything that applies to the entire body and is affecting the anesthesia. So patients with hypertension, diabetes, hyperlipidemia, all affect the entire body. And if they're not documented as complicated, or if they're documented as controlled, they're considered mild. Okay, so if it's not documented, it didn't happen. So unless they said it was severe, and you're going to determine that to be a systemic disease that is mild if it exists in the documentation. A severe systemic is going to be documented as severe or uncontrolled. And this is the difference between adding some additional units versus none. Okay, so if I have a P3, let's say my patient that came in for the appendectomy for an emergency service has diabetes that's uncontrolled. Then I'm going to add an additional unit from that modifier for that uncontrolled or severe systemic condition. Okay, so in the end, I'm going to determine the anesthesia code. I'm going to have my code here, 00100 through 01999 dash my provider who provided the services, we'll say it was a CRNA, which is QZ, dash my P modifier, P3, and then how many units times 5, 6, 7, 8, 9, 10, 11, 12 units. Okay, that's all for this Part 1 section of anesthesia coding. I want you guys to take some time to do some of the activities. Definitely pay attention to your discussion board this week and look at some of the videos, and then we're going to come back to this for a Part 2 later in the week. That's all for today. Have a great time, and we'll see you next time.